The following program was produced by an independent community producer. The opinions expressed do not necessarily reflect those of the ECAT staff or board of directors.
Well, hi, it's Kathy, and welcome back to my program, Purpose-Driven Aging. As your host each month, we focus on a variety of aspects of growing older, and we dive deeper into specific aspects of purpose-driven aging. Today, we're going to take a deeper dive into Medicare Advantage and specifically what it is like for you as a user when you have a Medicare Advantage plan. So overall, for my show that I want to do is to focus on the truths that are impacting elders and elder care and the importance of staying informed in a rapidly changing environment. So with me today is Grace Dotson, and Grace is a master's level RN, and she's been a guest on this show before. And she has myriads of experience in hospital settings in different areas of the country, in both academic medical centers and regional healthcare systems. So, hi Grace, welcome.
Good morning, Kathy. Thank you so much.
So a topic that impacts so many of us today is Medicare. And I know there's a lot of stuff going on out there in terms of misinformation, disinformation, and some of it may be true. So what we're here to do, if you have a Medicare Advantage plan or you're thinking about enrolling in one, or as we get into the end of the year and there's open enrollment, we want to talk to you about what being enrolled in a Medicare Advantage plan is. Now, I've done a different video on the differences between original Medicare and Medicare Advantage, so I don't want to go through all of those details there. But Medicare Advantage is a private health care plan, and it is operated by private insurers. And Medicare pays a fixed amount every month. So specifically what we're going to get into today is using Medicare Advantage with hospital services, transitional services such as moving from a hospital to home, a hospital to a rehab situation, and then using it in the community settings. So Grace, yes. I'd like to talk to you with all your hospital experience about understanding what people face when they come either into the emergency room or more so probably with this one, when they're admitted as an inpatient. And what kind of issues do people face when they're on a Medicare Advantage, and what did you and your department do with people that were on Medicare Advantage in terms of knowing if they're in or out of network, or dealing with denials and delays of care, and those kind of things. So I'll let you just jump in there and pick something that appeals.
Thank you. Well, so Medicare Advantage programs can be fantastic for people that are in good health and have good function of their body, their activities, daily living, and they're doing well, and they buy into a program that offers a lot of little perks, if you will. But when somebody's very ill and they are developing chronic illness, which is ongoing, or complicated illnesses that lead to multiple comorbid conditions, oftentimes these programs are not the best fit, because what looks good on the surface, when you get to the point where you really need the services, you may fall short. And you talked about deny and delay, and that is one of the barriers when a patient comes into the hospital. You may have information back and forth between the physician, the case manager, and the payer about level of care. Is this observation? Is this, which is an outpatient level of care, versus is this truly an inpatient admission? Very important for people to understand that. They would get a notice about that, and to understand what that means as far as coverage.
So when you talk about levels of care, so I could be a patient admitted into, say, the ER. Say I had a stroke.
Yes.
And God forbid, and say I was admitted into the hospital. So that's a level of care that I would need to qualify for And then maybe I would get to the point where I need to transition, which we'll talk about in a little bit.
Yes.
But how would I be leveled in a level of care in a Medicare Advantage plan versus if I was on original Medicare in terms of prior authorization? What is the trail between the two different ones to help people understand?
And it's quite different than straight Medicare, if you will. So a patient who has a Medicare Advantage plan, usually the case manager in most hospital settings, that's a nurse who has training in both utilization review and discharge planning, coordination of care. They are sending clinical information back and forth electronically or via fax to the payer. The payer then determines, this is inpatient according to their criteria, or this is considered outpatient. And the physician who admits the patient also certainly makes that determination. But oftentimes there's conflict between what the payer wants to approve for level of care and what the physician really would like for the patient to be covered as an inpatient. And so it's based on medical necessity, and where that becomes a problem, if you will, is when a patient who's, for example, had a stroke and now needs rehab. They need to go to the next level of care. Maybe they've stayed in the hospital 3 or 4 days, and they're making some progress with physical therapy, but they would really benefit from a full program of physical therapy, occupational therapy, maybe nutrition therapy, speech and language services, and oversight by a physiatrist, a medical director who is specifically trained in rehab. So the case manager works with the patient and family to see, what options are available for this patient. Could they go home? Maybe that's ruled out right away because there really isn't somebody to provide that 24/7 care and really provide intensive therapy. So they start that process with patient's permission or the caregiver's permission, who is a power of attorney, and begin to make a referral for rehab. That starts a chain of events, but oftentimes comes back as a delay. We want more information, and that's from the payer or the Medicare Advantage plan.
The insurer. The payer is the insurer. Yeah.
We want more information. You sort of have to negotiate, if you will, go back and forth, provide more clinical information. The physician who is the attending may have to make a phone call and give more information to the insurance plan medical director. And sometimes these denials are triggered by use of artificial intelligence by the payer, by the insurance plan, or an algorithm that they have who say, this patient is really, they've had a stroke, but they're lower risk. Let's send them home because it's less expensive.
So what happens is you've got the medical people that are right there,
yes,
looking at me, the patient,
yes,
and where I am, how I qualify, what's the appropriate Medicare coverage for this level of care. So when I get to a point where I don't need hospital level services, but I may need continuing services in an institutional setting because it's hard to go home because I don't have the care there, this is where it goes back and forth between the private insurer and the medical people in the hospital. So that causes the delay.
Yes, it does.
And then sometimes it can be denied. And you brought up an interesting point where there's AI and algorithmic input. So the way this works is information, it's just like with any computer system, is put into, a program, and it spits out what the appropriate level of care is,
yes,
even though that may not be the best for the patient medically.
Yes.
So when there's a denial or this, how does a patient appeal? Like, if I have a Medicare Advantage program, what can I do if something is denied and I'm in the hospital and I feel like what's the process?
It certainly can help if the patient has been informed of a denial by the insurance plan, and that's usually after the physician who is the attending for the patient, has made an appeal on the telephone and gone through a certain process, but it has failed, and now the payer is denying. It certainly helps for the patient or their caregiver to make a phone call and to really start that process to advocate to get the denial overturned. And it may make a difference, but not always. Not always.
Yeah, so what we're seeing is with the Medicare Advantage plan, there's much more this administrative process that delays and denies, where with original Medicare, if I'm for the same situation, the same patient, with Medicare with a supplement, then the transition of care would be much easier.
Absolutely, absolutely.
So while we're on hospital level care, what happens and how do I get assured that if especially like say in Massachusetts, it's a tourist area, sometimes there may be people from different parts of the state, and Medicare Advantage works with network providers.
Yes.
So what happens, do hospitals check to see if the patient is in network? How does that work in the hospital when you have a patient?
Yes, and so your nurse case managers are working fairly closely with the people who do the registration and the financial check when the patient comes into the hospital. And there may be dialogue through the computer usually or the telephone back and forth on, okay, this patient has an out-of-area network, they have limited resources, they may not have coverage, for example, to a local physical rehab, but they need that level of care. They meet medical necessity, they need that. And so in that case, the case manager working closely with the physician, and we may involve the family too and the patient to challenge that with the insurance provider to get a one-time single contract, if you will, because the patient truly needs that level of care.
Yeah.
And there's no existing contract because they're from out of the area, or the network of providers is very narrow.
So, and that happens with Medicare Advantage. You know, you have to stay within network to get reimbursed. But sometimes, people travel, we have lives and stuff like that. And then maybe a stroke, an initial stroke is an emergency situation.
Yes.
So if, somebody, or an accident or something that's unforeseen. So, I'm taken from ambulance to, usually the closest hospital is the way it works in an emergency situation. Yes. So can that person still get care, even though it's out of network?
Absolutely. When a patient is brought into the emergency department, or the emergency room, as some folks call it, they will be seen. They will be evaluated, treated, and that's under EMTALA regulations. So,
can you explain what EMTALA is?
Well, those are protection regulations and laws in place to protect patients who, maybe a mother who's in labor or about to give birth, and you wouldn't want to transfer her and risk the life of the mother and the baby, transfer her to an existing hospital that's in network, for example. Or somebody who's having an active stroke that's evolving, you certainly don't want to delay their care. You want to get them into emergency services, treated, evaluated, and and then when they make the decision as far as admission and such, there may be a back and forth with the insurance plan to say, your patient's here, but it's too high risk to transfer them out, 100 miles to your network. And, again, they're going for that one-time contract.
That's what I was just gonna. So you mentioned, this transition and moving to rehab. So you have a level of care that's hospital level of care.
Yes.
And reimbursed by any insurer, really, but the Medicare Advantage at this level.
Yes.
So now I am going to the next level of care, okay? So that would be either rehab or home. So let's assume I'm not stable enough to go home, or I need more intensive therapy to improve, whether it's a cardiac event, an orthopedic event, or a neurological event such as a stroke.
Yes.
So how is the decision made whether I go to acute rehab, subacute rehab, or home?
Great question. And again, we look to the nurse case managers who, and that may be a social worker also, it's not just nurses, but sometimes social workers in the hospital setting who are very well versed in transitions of care and looking at the level of care that's most appropriate for the patient based on what resources are available or what level of care they really need, hands-on care and treatment. And then, remind me, Kathy.
So then when you're going from subacute to acute care
Yes.
rehab,
Yes.
so one of them is more intensive.
Absolutely.
So acute rehab would be getting three hours or 4 hours of actual physical rehab a day, and you have to be strong enough as a patient to
That's
undergo
correct.
that,
Yes.
as opposed to, say, a SNF, skilled nursing facility, or subacute rehab, which has less stringent criteria in order to be paid by the insurer.
Absolutely. And there's a couple of things around that. One is if the patient comes in and they are having what's called a TIA, which is, you know, it looks
mini
like
stroke,
it may be
yeah.
a mini stroke. So they may come in under observation, which is outpatient. So that observation period, maybe it's a day or two, and then maybe it evolves into a full stroke, and the patient becomes an inpatient at that point. But those observation days that are outpatient may not count towards that 3-day qualifying stay to go into a subacute rehab. That's important.
And this comes up so much. It did
Yes.
in my practice. And one of the things I want to bring up now is that feeling that people are entitled to 100 days of rehab once they leave the hospital. And there is a sense where, you know, once I'm admitted to a rehab, I can stay for up to 100 days. And families actually plan around this. And it's never been this way. It's not that there's a change. It's never been, because it's all driven by this medical necessity
Absolutely.
that which exists in not just hospitals, but acute rehab, subacute rehab, and home care.
Yes.
And the clinicians, the people that are providing the care, are the ones that have to document why you need this level of care as a patient. So can you talk about that observation versus inpatient in that 100 days, and what is the criteria from an insurance point of view that if someone's observation, then they may not open up that window, right? For
That's correct.
acute rehab or subacute rehab.
Well, I wanted to bring out an important point, which is for an acute rehab stay, and let me back up a little bit further. A case manager in the hospital setting is usually looking at Plan A, Plan B, Plan C in their back pocket when they look at a patient's care needs. So they want to start with the highest level of care that they can get the patient into, and that may be a full acute rehab program with all of the services, and very intense program, 3 hours of therapy a day, usually divided into 2 sessions, with a care plan and a whole team really around the patient. If the patient doesn't meet medical necessity for that, then they're looking at, and they stagger it, then they look at subacute, which is usually in a nursing home setting, but it's short-term rehab. If the patient goes to acute rehab and is accepted, they don't have to worry about, gee, they were observation. They still can go right over. However, the rules are different if they need the lower level, the subacute rehab.
So it's only for subacute that the
That's
100
right.
days apply.
Yes.
Because you're still under, you know, you go right on. It's like an acute to an acute.
Yes, it is.
And the same with LTACs and things like that.
That's correct.
Which are long-term acute care hospitals. But where most people go is into what, you know, they consider a nursing home, but nursing homes have 2 levels of care. They have one that does the rehab and the subacute, and then they have another, which is long-term care, which isn't part of this discussion because it has a totally different payer mix.
Yes.
So for someone that's observation or inpatient, Part A or Part B, right? Whether
Yes.
it's Medicare Advantage or whether it's Medicare, both parts are still doing their thing.
Yes.
So how was the decision made whether someone is observation or inpatient in the hospital situation? Because this is what opens the window to that subacute.
So as the patient arrives to the emergency department, if you will, maybe transfers up to the floor within 12 hours or so, the nurse case manager has utilization guidelines, and they're clinical guidelines that are evidence-based. They're using that to look at what level of care is really the best fit.
Yeah.
But they're also working closely with the physician that's admitting the patient. The physician that's admitting the patient determines the level of care ultimately, and may admit the patient as an inpatient. However, you may have feedback once you share information with the payer, with the
Which
Medicare
is the
Advantage,
insurance, yeah.
and they may say, no, we're not paying for inpatient. We're going to determine this to be outpatient observation. And then again, that may start a back and forth with an appeal process.
And when we're talking about level of care, for simplicity, we're talking about levels, the acuteness of illness. And sometimes people can come in and be treated and actually improve within a short period of time. And they come in very, very sick, and they may have some level of disability or functional loss through this. But then you have someone who may come in and say, I'm thinking of a heart attack. You come into the emergency room and it may be mild at first, and then symptoms may start to exacerbate. And their blood work is being watched, and EKGs and all that, and may end up in the cath lab and may end up really a lot worse. So this is why the observation makes sense in some situations, to make sure that you're going to level out at this level of care, or you're going to become sicker.
Yes.
And may end up as an overnight, and then that opens up. So this is what level of care means, what your clinical presentation is doing in different levels of care. And this is, you don't want to know all the details behind it. But what we're doing with transitions, I also want to get into transitions to the community, because not everyone needs acute rehab or rehab afterwards. Many people can do really well at home. And one of the things that, where I spend a lot of my time is in the home care environment. In Medicare, whether it's Medicare Advantage, also provides home care services. Now, there are two different types of home care services available. One is private, which you pay out of pocket, which is, home care aides and people that help with functional loss. And then there's acute care, which is home health care, your VNAs, maybe your candidate for hospice or whatever, where you have nurses and therapists and other professionals coming in. And they're driven by medical necessity for the home care piece too.
That's correct.
So when you're discharging someone from the hospital and they're eligible for home care, how does the whole network thing and the delay and the denial work on that end?
Well, it's similar in that the insurance plan will look to see, for example, maybe a referral is being made to a local visiting nurse agency. Are they in network? If not, maybe work together for a one-time, contract to provide the care for the patient. When the patient arrives home, there's a full assessment that may take an hour and a half up to 2 hours, where they're looking at the home environment, who are the caregivers, what medications is the patient on, what kind of therapy will they need. So there's
equipment.
Absolutely. They're looking at the full needs of the patient. But what many people don't understand when they need home care for the first time for themselves or loved one is that home care through a visiting nurse agency is almost always intermittent care. So it's an hour, a couple times a week. It is not every day for 8 hours, 24 hours. It is not providing the types of services where somebody's staying in the home and they are doing housekeeping and they are cooking for you.
Or helping with bathing and dressing and that kind of thing. It's strictly a visit type of process.
Yes.
I'm in, and after that initial opening of the case, then the future visits are focused on a specific task, a specific area, and it's in and out. And the same thing with physical therapy, the same thing with occupational therapy and any other services you have under the Medicare Advantage or any Medicare reimbursed type of service in the home. Now, where things are a little different, go ahead.
I was going to say, and the patient needs to show progress.
Yeah.
So that, if they are maintaining or they've kind of plateaued, they may reach a point where those services are no longer available because they're not showing improvement.
And that's true in any rehab setting. That's one of the levels of care that, you know, once you reach a certain level and you're not going to improve, you know, you're the best you're going to be right now, then the insurance will cut off. One of the things I wanted to touch on in the home care piece is Medicare Advantage plans, some of them do promise, or do promote, I should say, that they pay for meals, they pay for in-home services, they pay for transportation. So the thing to remember here is that it's very limited. Sometimes they're hooked to a discharge from a hospital. In other words, if I'm, you know, sitting at home and I'm struggling and I need these services, the plan will not just automatically turn on the spigot.
That's correct.
If I'm just coming home from the hospital, they may be limited meals, transportation, some in-home care that's not paid for by Medicare. But this varies by plan, it varies by region, and each person who's enrolled needs to look to see what their plan will and will not provide. But specifically, the VNA approach, the skilled approach that Grace was describing, is pretty consistent across the country.
Yes.
And, you know, that is an option for people. And, you know, you're given your little certificate of choose 3 right, or, you know. So as we close this out, Grace, is there anything you want to add?
I would say buyer beware. So if you are looking at Medicare Advantage programs, and there are a lot of them out there, look deeper and don't just look at what I call the bells and whistles, or, oh, you'll have these meals, you'll have this transportation, you'll have eye coverage. Look at it very closely and bear in mind that these programs are very profitable, usually, for the insurance plan. So they are really focusing their sales, if you will, on people who are fairly healthy. If people have chronic illnesses, complex illnesses, they're in and out of the hospital a lot, those patients may run into more problems with delays and denials for prior authorization or for approval to get the care that they need. So bear that in mind.
And I think, you know, for anybody that's either enrolled in any plan or is coming up, what we call aging into the Medicare program itself, local resources in Massachusetts, they're called Shine Counselors. They're available in every community. And across the country, they're called SHIP Shine, and they provide a wealth of resources. So you can get down to your individual level and kind of determine what's the best program for you and your family. So I want to thank you, Grace, for sharing your wealth of wisdom with this. You know, it sounds in the 30 minutes we've been here like, you know, it's as easy as that. It is not. Every case brings its own challenge. And even if it were me who had a stroke or a heart attack or somebody else, there'd be 2 different ways this would need to be managed, even if the insurance were exactly the same and we were the same age, because we're different people. But I want to thank you and talk for myself and for purpose-driven aging, which I consider not just about getting older. It's about living each day with meaning, making a difference in the world. It encourages us to approach life with purpose, passion, and intention. So that's all for today's episode on Medicare Advantage, how you're using it, what really goes on behind the scenes, what you need to know. So we'll see you again next month, and we'll continue talking about these topics and areas that confuse the heck out of all of us. So until then, take care and embrace your journey as you age.